Well, hello everybody. My name is Mirvat Al-Aslaj. I'm the chair of the International Working Group of the SCCT's Education Committee. And we have a very exciting program today that covers cardiac disease diagnosis. And it's sponsored by Bayer. Now, without any further ado, I want to introduce our first speaker. And I'm sure you're going to be very excited to hear the talks that are coming up in this space. Our first speaker is Manesh Motwani. And he's going to cover the European and US guidelines on acute and chronic chest pain. Manesh is actually very well known in the community. He's a cardiologist and physician scientist at Manchester Heart in the United Kingdom. He specializes in non-invasive cardiac imaging, including cardiac CT, MRI, echo, and advanced nuclear techniques. And he's trained in several renowned places across the globe, including Leeds and Cedars-Sinai in the United States. And his PhD studied advanced quantitative imaging techniques in coronary artery disease. So I'm sure there's a plethora of information that he's going to give us over the next few minutes. Now, he has served on the CT training accreditation committees of both the EACVI and the SCCT and is currently serving in the SCCT Education Committee. So Manesh, over to you.
Thank you very much for that kind introduction and the invitation to talk to you today about European and US guidelines on acute and chronic chest pain. So clearly this is a very large topic. These guidelines are large, they're comprehensive. I won't be able to cover every single aspect. So what I'm going to do is I'm going to focus on the imaging perspectives, mainly CT, and draw some comparisons between the two guidelines across the Atlantic and draw your attention to some changes since their last iteration. So this slide offers the documents that we are discussing. So on the left here, you have the two European guidelines for a chronic chest pain scenario and acute chest pain scenario. And then you have the US guidelines here on the right, which are a composite of both acute and chronic. Although this may be a bit of a boring slide, there are a few things of interest that we can point out. The US guidelines are truly multi-societal. All these societies have been involved. They're multi-modality. They're designed to give very broad consensus of opinions across these societies and modalities. And the other thing to say is they have changed their terminology. They refrain from using the term stable ischemic heart disease, and they refer to chest pain. Chest pain is put up front and center. So these guidelines are built around that symptom of chest pain, and therefore the guidelines also include information about non-cardiac causes of chest pain and strategy around that. By contrast, the European guidelines instead do not talk about chest pain and prefer actually to use the terminology chronic coronary syndromes. And there's a reason for that. So they've changed the terminology from chest pain to chronic coronary syndromes, as I'll explain in the chronic scenario. And then the acute scenario, you're familiar with the term acute coronary syndromes and all that goes with that. So it's interesting, they've changed terminology in polar directions, but both for justifiable and good reasons, as I'll explain. So if we start with the European guidelines, this schematic describes the chronic coronary syndrome situation. And you can see within chronic coronary syndrome, you have different phenotypes of patient. You might have a patient who's low risk, has a low burden of symptoms, but does require revascularization at some point. They're medically well optimized, and they do pretty well. Equally so, you may have a patient at higher risk with a high burden of symptoms, ends up having an ACS and continues on an adverse risk profile. And then you may have these patients, which we'll all be familiar with, that have chronic coronary artery disease, and they keep having ACS after ACS after ACS, and they keep chipping away. And clearly, all of these patients have chronic coronary artery disease, but they're very different phenotypes. So these guidelines felt it important to have a term that covers all of them, chronic coronary syndrome, and a guideline that addresses all of them in different ways as they're different patients. So this is an interesting concept. and it differs from the terminology on the US side. Now, they appreciate their guideline is extensive and you have all these different scenarios. So what they outline from the beginning is that there's probably about 6 different clinical scenarios, and it's worth you taking a minute to work out which of these scenarios your patient belongs to before engaging with the guideline, because it can really make a tangle into a nice neat structure if you're able to categorize your patient well. So broadly, your patient may be a patient with new stable inguinal symptoms, so you want to evaluate them for chronic coronary artery disease. It may be a patient with new onset heart failure that you believe relates to chronic ischemic cardiomyopathy. It may be a patient who's known to have prior revascularization, but who is within a year of the revascularization and therefore clearly needs ongoing close medical optimization. Or it might be a patient who's 1 year out from the revascularization and you're maybe looking at different aspects for that patient. It could be a patient who's moved through various investigations and who you feel has vasospastic or microvascular angina, and so there's guidelines pertaining to that. Or it might be a patient who's actually come to you through screening, who may be asymptomatic, but in whom coronary artery disease has been detected in a screening program, and you need to understand how to move that patient forward. So what are the major recommendations, new major recommendations in this 2019 guideline? Well, the first thing to state is that imaging is put up front and center. So no longer is treadmill testing the first line. It's all about imaging, and that could be ischemia imaging, or it could be anatomical coronary CTA imaging, but either way, imaging is the initial test. The selection of the test will be based upon this concept of clinical likelihood of coronary artery disease, which I will explain, but this is essentially a modified pre-test probability, which I will come on to. Now, although imaging is up front and center, these guidelines do allow room for direct invasive angiography in a small group of patients who they describe as very high clinical likelihood of disease with a very high burden of severe symptoms. And in those patients, if you're going direct to invasive angiography, it's important that you have the availability of invasive functional evaluation, because these guidelines do not pitch anatomy versus ischemia. You'll see throughout these guidelines that they view the anatomy and physiology as complementary aspects and assessments, that all patients will ultimately move through both assessments, as you will see. These guidelines also allow room for clinical acumen and common sense. If you have a patient who can't hold their breath, you don't just move forward with coronary CT because the guidelines suggest so. So you have to use the right test based on clinical factors out with the recommendations. So what are the changes from the previous iteration, 2013? The main changes are, as I've already outlined, is that there's a movement away from treadmill testing to actually imaging-based testing. You might still use treadmill testing in a very small select group of patients. For example, those who you may wonder whether their symptom is actually an exertional arrhythmia, or to see the BP response or their exercise tolerance, but generally imaging first. There's also an appreciation in these guidelines about microvascular angina or vasospastic angina, and there's therefore a reference to, if you believe you have a patient with one of these conditions, there's reference to guide wire-based coronary flow reserve and circulatory resistance testing. This slide gives you the basic blueprint of how they suggest chronic coronary syndrome or chronic coronary artery disease is assessed, and it's essentially 5 steps. The first few are, as you'd expect, clinical history, some basic tests and risk stratification based on clinical factors, resting ECG, biochemistry, hematology. All patients have an echocardiogram at rest. chest X-ray in selected patients, for example, if the presenting symptom is more dyspnea or there are respiratory co-pathologies. And then you come to this key step, which is assessing the pre-test probability and clinical likelihood of coronary artery disease. And if this comes to more than 15%, I'll explain how the testing is done or how the probability is done. Then you move forward to diagnostic testing with some form of imaging. In the group where the probability is very low, like under 15% or certainly under 5%, there's no mandated testing required. These guidelines advocate that in the low to intermediate group, coronary CTA is preferred, and in the intermediate to high group, ischemia imaging is preferred. And as I said, there is this allowance for the very high risk, high symptomatic burden group to have invasive coronary angiography first. Based upon the outcome of these tests, appropriate treatment will be instigated. These guidelines allow for variance based on local expertise and availability, which is just common sense, but it's good that that is stated. So this outlines step 4, how to conjure up that pre-test probability. There's some text in this document that explains that in previous times, using Diamond and Forrester classes, substantially overestimated risk by up to a third. And to some extent, that explains high normalcy rates for tests in times gone by, and that has a cost burden. So this pretest probability is derived from new contemporary data of about 16,000 pooled patients. It's based upon the patient's typicality of chest pain and then their age. Typical angina is described as having all 3 of central chest discomfort radiating to neck, arm, or jaw, and exertional nature, and relief by rest or nitrates. If you have 2 out of those 3, you have a typical angina, or if you have less than 2, then this is probably non-anginal. And then there's the table for dyspnea. So what these guidelines suggest is that if the pretest probability is more than 15%, which you have here in dark green, then there's sufficient evidence or sufficient recommendation to move forward with diagnostic testing. In groups less than that, there's no there's no mandate to move forward with diagnostic testing. And in fact, recent data suggests that this 5 to 15% group, when they are tested, it actually is less than 5% that have significant disease. So this is a very low risk group, below 15%, as per the data referenced in this guideline. However, what they do allow is modification of the pretest likelihood by additional clinical factors, most significantly by cardiac calcium, for example, on a prior chest CT, or very abnormal ECGs, such as that with Q waves, or maybe familial dyslipidemia. So yes, it is pretest probability, but they suggest modifying that with certain clinical factors, and that is what then gives you this new term, clinical likelihood of coronary artery disease, which then drives forward your investigation pathway. So which test do they recommend? Well, as I said, in the low to intermediate group, they suggest coronary CT first, and that's because in that low intermediate group, it's very good at ruling out coronary artery disease. And the ischemia test, here you have PET, stress CMR, are very good at ruling in disease in the intermediate to high group. But actually, there's not that much difference between these advanced modalities of coronary CTA, PET, CMR, and stress echo. They all significantly overlap in the intermediate strata of 50%. So they're all pretty good. But if you have availability of all, then in the low intermediate group, start with CT, and the intermediate higher group, start with ischemia. That's the recommendation in these guidelines. But as I said to you, these guidelines are not absolutists, and there's an appreciation that if you follow the guidelines, all patients will end up having both anatomical and functional imaging, just by the way the pathways work. So, for example, if you have coronary CT first, If that is borderline, you'll then go to ischemia testing and then come back to invasive coronary angiography. If you started with non-invasive ischemia testing, if that was abnormal, you'll end up having anatomical testing with invasive coronary angiography. If you started with invasive coronary angiography, you will end up having functional assessment invasively. That's how these guidelines work. So whatever strata of pretest probability you're in, and wherever you entered the pathway, these guidelines generally exit you having had both anatomical and functional assessment. So in long-standing patients, just a little bit about follow-up. They're very clear that routine, indiscriminate follow-up coronary CT is not recommended in asymptomatic patients. Often patients ask for that, but it's not a recommendation. They advocate for clinical follow-up, clear discussion of symptoms, rather than further testing routinely. And because this comes up often, it's worth just seeing what they say about asymptomatic screening. So their viewpoint is that in individuals over 40, yes, clinically risk score them, absolutely, but not routine imaging. In patients under 50 with very adverse risk factors such as familial hypercholesteremia or family history, again, clinically risk score them. There's not a mandate to routine screening, but they do offer a soft recommendation that coronary artery count scoring can help modify risk in these groups who have particular concern. Right, moving on to the European guidelines for acute chest pain and acute presentations. There's less to do with imaging in these guidelines. Obviously, acute presentation is assessed with history and examination, ECG, and in Europe, high sensitivity troponin, which we've had probably about decades. That's really the discriminator. Those combination of factors will bucket your patient either into unstable angina, NSTEMI, or STEMI, for which you'll move on to an appropriate clinical pathway. It's worth just thinking a second a bit more about NSTEMI. So obviously history, examination, ECG, and then the high sensitivity troponin algorithm is at 0 and 1 or 0 and 2 hours, looking for a delta shift in that, and it's very sensitive. So obviously that will then allow you to discern with some confidence if the history is unlikely and those the troponin, high sensitivity troponin, ECG are normal, then you've ruled out this patient. If the ECG or high sensitivity troponin are positive, you've ruled in. And then there's this middle group who you're not sure about the history. The high sensitivity troponin is normal, and the ECG is normal. So in these patients, they recommend observe. You might end up doing a full 12-hour troponin, and the observation period then allows the patient to unmask themselves with further chest pain, which upgrades them, or ECG changes, which upgrade them. In that intermediate group, there is a 2A recommendation or consideration that you might move them forward with coronary CT or non-invasive stress imaging, but the default is observation and C. And this is a little bit of a distinction from the US guidelines, which we'll come up to shortly. So there's no recommendation for early coronary CT routinely in ACS patients. Obviously, all patients will have an echocardiogram. And for the first time, there's reference to cardiac MRI, its role in these patients presenting with acute chest pain, specifically because some patients go on to have invasive coronary angiography with normal epicardial coronary arteries, and there's an appreciation of the particular role of cardiac MR there in identifying myocarditis, Takotsubo, or genuine Minoka MI with non-obstructive coronary artery disease, etiology being either spasm or a plaque rupture with spontaneous recanalization. So MR is very strong in that, and there's a whole section referencing that. Okay, moving on to the US guidelines. So if you were to be cynical, you'll consider that they've changed the name to chest pain so they could have this cool graphic and pull out these these 10 points that each correlate to a particular letter. But important points in this graphic are that they put chest pain, the symptom, up front. They explain that women may present more unusually with different types of symptoms. They want us to refer to non-cardiac chest pain rather than atypical chest pain, because atypical is confusing sometimes. Is it atypical angina or is it atypical for the heart? So be clear if you think the pain is cardiac, probably cardiac, or non-cardiac. And there's various other points that they pull out to make this mnemonic work. As I said, they put symptoms front and center, so they explain a bunch of symptoms that can be cardiac or associated with cardiac disease, and they want you to call them cardiac, possibly cardiac or non-cardiac. And again, there is this appreciation of different presentations depending upon gender. Ultimately, the acute chest pain assessment is very similar to European guidelines, obviously history, ECG, troponin. Obviously, the troponin here in the US tends to be more conventional troponin rather than high sensitivity troponin. And that means that this intermediate group, there's a bit of a drive actually to have another layer of testing with imaging. So that's a difference between the European guidelines. So in this intermediate group, so normal ECG, normal entry, standard troponin, uncertainty can be clarified by moving onwards to CT or stress imaging. If you have a CT, obviously, if there's a severe stenosis, you move forward. If you've ruled out disease, you've ruled out, you can be discharging. And in the intermediate stenosis group, for the first time, these guidelines also advocate the use of FFRCT to get further information on that intermediate lesion. And this may then end in invasive coronary angiography or medical treatment and medical management, depending on the outcome of that. And similarly, if you chose to have stress testing because of availability rather than coronary CT, you then move forward either based upon the presence or absence of ischemia towards invasive angiography. In the chronic side of these guidelines, assessing chronic coronary artery disease, it's very similar to the European guidelines. They want you to assess pretest probability with a similar grid. This time, the chest pain is not divided by typicality, but it's just chest pain or dyspnea. But again, the number is 15%. If the pretest likelihood is more than 15%, there's mandate to move forward with testing. And they also do emphasize the role of coronary calcium on, for example, prior chest TT or formal CAC scoring that will up-modify this risk assessment to higher risk groups, which can help make which can change a patient from lower risk to higher risk if there's also significant calcium. They're not absolutist in which imaging test you start with, but they suggest that in the intermediate group and younger patients, you start with CT. In the older group or higher risk patients, you start with stress testing. But again, they allow for local expertise and availability. In the US guidelines, they do not have a group that advocates for direct to invasive coronary angiography. And this is very similar ultimately to the European guidelines, having ascertained there is a more than a 15% pretest likelihood you move forward with testing, which if it is stress testing and there's ischemia, if it's very minimal, you might stand there, but if it's more than minimal, you'll move forward to anatomical assessment with invasive coronary angiography. And if you started with coronary CT, and that is abnormal, you may then move forward to functional imaging, either with FFRCT or stress testing, and depending upon all of that, you may end up with invasive angiography if appropriate. So the point of that spiel of mine is to clarify that similar to the European guidelines, all patients ultimately tend to get both functional and anatomical assessment wherever they enter the pathway. So in summary, very quickly touched over these guidelines. They are the same, but they're also a little bit different. A llama and an alpaca or the other way around, I'm not sure. The acute guidelines in the European guidelines, these are driven by clinical and high sensitivity troponin. In US guidelines, because there's less availability of high sensitivity troponin, there is more imaging in the intermediate ECG normal troponin negative groups. That's one difference. In the chronic guidelines, there's lots of similarities. Both advocate for these revised pretest probability scores, which are lower risk than legacy. Both suggest a 15% threshold for imaging assessment. Both suggest testing may not be needed in a low risk group. Both advocate for clinical acumen and local expertise factors. Both put CT first in the low risk and intermediate risk groups. Both have pathways that ultimately accrue anatomical and stress data. Both recognize MINOCA and INOCA. Both have increased reference to diversity factors and female-specific presentations, which is a great thing to see. Both have changed terminology, but in polar direction, but both with good arguments. And one point of difference, the US guidelines now include FFRCT recommendation for sequential use as a substitute for stress imaging in patients who have already had CT. Briefly, UK guidelines fall somewhere in between, but I've included this because 10 years ago they moved to a CT first strategy independent of pretest probability. And what you can see as CT use has skyrocketed, you can see that mortality has actually decreased. And I include that only to make the point that if guidelines are followed systematically, it can have a significant prognostic impact. So despite all these guidelines being lengthy, it's important to get familiar with them so their extensive recommendations can be implemented. So obviously that was a very quick rush through, but I hope you picked up some of the key points. Thank you very much.
Well, thank you, Manish, very much for this very thorough cover of the guidelines, both European and Americans, and I really like that last slide that kind of draws the parallels between both of them. We have a couple of questions in the Q&A. One of them is about what is the maximum calcium score we can stop CT angiography. I think what they mean here is at what level of calcium would you say the CT is not informative and I'm not going to proceed with an angio segment?
Okay, that's a good question. It's not something the guideline for chest pain specifically covers. Various CT guidelines do look at that. There's an very old threshold of 400, which is not contemporary at all. There are new thresholds of 1,000, but really it depends upon your scanner, your local kind of expertise. For example, if you had a photon counting scanner, there's really no limit. So you get to know what is the threshold in your local scanner. I personally start questioning it when we're at 1,500, but also it's amazing sometimes you do scans with calcium 2000 and you get a lot of information. If you can ascertain if a patient has a significant left main lesion or proximal LAD, even if you can't read the rest of it, that's still a step forward. So generally, if you've rate controlled the patient's on the scanner, you've got a good history, they're all prepped, I do tend to proceed in general, because I think there's still useful information in most cases.
And I think the next question is also very important, particularly in an Asian population and even in the Middle East where I practice, our patients are much, much younger. So what do we do with young patients in their 30s and so on that come with chest pain, where a coronary calcium score and so on, the yield may not be significant there? I mean, they may not have high calcium scores.
Yeah, this is the importance of having guidelines that are not just North American based, not just European based, but are global and take into account lots of diversity factors and regional factors. There isn't, if the patient has chest pain, then they can still move forward in the algorithm and have coronary CT in the way that's been described, but you'll be looking more for non-calcified plaque. There's a difference in young patients who are asymptomatic and you're thinking about screening, and that brings up a whole nother bag of factors that these guidelines don't cover.
Well, thank you. And just to stay on track, we're going to move on to the next presentation. And our next presentation is going to be by Dr. Sun Min Ko. He is going to discuss cardiac CT techniques and optimization for diagnosis and risk assessment in chest pain patients. And perhaps that may answer some of these questions. He is the head professor and director of Department of Radiology in Yonsei University, Gwangju College of Medicine. He's also the director of Cardiovascular Center of Yonsei University. And I won't delay you much more, just so that you can go ahead and start your talk, please.
Thank you for a kind introduction, Chairperson. It is my great honor to present on CT cardiac techniques and optimization for diagnosis and risk assessment in a chest pain patient. Both non-invasive and invasive diagnosis testing play essential roles in the evaluation of a patient with chest pain, whether it is acute or stable. Today, I would like to divide my talks into two parts: stable chest pain evaluation and acute chest pain evaluation. A very interesting debate regarding cardiac CT should be the initial diagnosis test in patients with suspected angina was recently published in the European Heart Journal 2023. The NICE guideline recommended cardiac CT as the first-line investigation for patients with stable chest pain and an intermediate likelihood of coronary disease. The ESC guideline emphasized a more personalized approach, taking into consideration not only the clinical assessment but also the patient age and sex to determine the appropriate initial diagnostic test. Coronary CT angiography was recommended for patients with a low to intermediate pretest probability of coronary disease. Both non-invasive and invasive diagnostic testing play essential role in the evaluation of patients with stable chest pain. Coronary CT angiography is used to evaluate patients with stable chest pain who are at intermediate to high risk of developing major coronary disease. Coronary CT angiography allows for quantification of coronary stenosis, has an excellent correlation with invasive coronary angiography. The volume rendered image and the curved multiplanary formatted images show significant stenosis with non-calcified plaque in the mid-LAD. Invasive coronary angiography confirmed significant stenosis of the mid-LAD. This image was obtained 18 years ago by using 6-pore CT scanner. Today, coronary CT angiography is considered to be the non-invasive imaging tool for the evaluation and the management of coronary disease in clinical practice, serving as gatekeeper before invasive coronary angiography. With the help of artificial intelligence, automated quantitative coronary stenosis and atherosclerotic plaque imaging is possible. This young woman presenting with atypical chest pain had an anomalous origin of right coronary arising from the left sinus of valsalva with interarterial course on CT coronary angiography. Machine learning-based CT FFR is available for research purpose only. Machine learning-based CT FFR for proximal RCA was within normal values. Coronary CT angiography can classify atherosclerotic plaque types, including calcified, non-calcified, and mixed plaque, and can be furthermore identify high-risk plaque feature, including spotty calcification, nap-killing sign, and the low attenuation plaque and positive remodeling. However, coronary CT angiography does not predict hemodynamic significance of coronary artery stenosis. This patient had very severe stenosis with non-calcified plaque and positive remodeling in the middle right coronary artery. However, left coronary CT angiography did not show any hypoenhancement in the LV myocardium. Stress and rest cardiac MRI showed reversible perfusion defect in the mid-inferior and the inferior septal wall corresponding to right coronary artery territory. Invasive angiography confirmed the tight stenosis in the middle RCA. Three types of CT microperfusion imaging: static single energy CT MPI, static dual energy CT MPI, and the dynamic CT MPI are available in clinical field. Each of these three CT MPI has its own advantages and disadvantages to identify hemodynamically significant CAD associated myocardial ischemia. Particularly, I would like to emphasize on the dynamic CT microperfusion. Dynamic CT microperfusion can obtain quantitative data of microblood flow and coronary flow reserve using dual source CT and wide area CT scanner. This is the typical case of dynamic CT microperfusion imaging. Coronary CT angiography showed extensively calcified plaques in LAD and left circumflex artery, particularly more severe in left circumflex artery. Dynamic CT MPI showed reduced microfluid flow in LCX territory. Proximal LCX 90% stenosis was noted on invasive coronary angiography. Recent multicenter study demonstrate dynamic CT myocardial perfusion offered incremental diagnostic value over coronary CT angiography alone for the detection of hemodynamically significant CAD. This study result encourages broader consideration of dynamic CT MPI in the clinical evaluation of patients with suspected CAD. Based on the updated CAD Hedrod classification, CT FFR or CT perfusion may be used in the coronary artery stenosis ranging from 50 to 90% to better define if a stenosis is hemodynamically significant, particularly Cadolad 3, moderate stenosis, and Cadolad 4, severe stenosis. This slide showed clinical decision pathway for patient with stable chest pain. In patient with stable chest pain with or without non-coronary disease, a combination of coronary CT angiography and FFR CT or stress testing may be helpful in identifying which patient with stable chest pain need invasive coronary angiography or guideline-directed medical treatment. Today, coronary CT angiography became the cornerstone of first anatomical approach for assessing chest pain. Even though CT FFR is a very promising imaging method to identify hemodynamic significance of coronary disease, like this case, there are several potential concerns and negative views associated with the use of CT FFR, particularly including its excessive load, limited availability, limited information on efficacy, and high cost. This slide shows which imaging test is preferred based on the pre-test likelihood of CAD, study goal, and other compelling indications. The combination of CT microperfusion imaging and CT coronary angiography provides the benefits of both functional and anatomical studies at the same time. This video shows how to perform the dynamic CT perfusion using third generation dual source CT at my hospital. It usually takes up to 25 minutes for coronary calcium scan, dynamic CT perfusion, and coronary CT angiography in serial order with well-trained radiology technicians and nurses. 5-minute delay scan is optional between stress dynamic perfusion and the rest coronary CT angiography. This slide summarizes the entire process of study protocol. Coronary calcium scan, stress dynamic perfusion CT using ECG-triggered axial shuttle mode, 10-minute interval, and the rest CCTA were performed sequentially. Dynamic CT perfusion acquired by dual source CT with the shuttle mode suffer from inhomogeneous contrast phases between the top and the bottom of the image. On the other hand, wide area CT using Ocular 1 Prism CT shows ISO phase of contrast and better image quality. These videos illustrate the situation of two perfusion acquisition ways, dual source CT with shuttle mode and wide area CT with no table movement more straightforwardly. Let me show you several interesting cases of CT perfusion imaging. Severe coronary calcification of three vessels with extensive plaque burden was not associated with LV myocardial perfusion defect at dynamic CT perfusion. There was no significant coronary stenosis on invasive coronary angiography. 59-year-old man complained of chest pain. CCTA and dynamic CT perfusion studies were performed with low concentration iodine contrast media. Three vessel disease was strongly considered in CT angiography. Dynamic CT perfusion image shows a significant decrease in micro blood flow in the middle LV wall except inferior segment. Invasive angiography confirmed mid-RCA occlusion and significant stenosis in the proximal to mid-LAD and distal LCX. This CTA demonstrates non-calcified access plaque with positive remodeling in the left main coronary artery and the proximal left anterior descending coronary artery. Invasive angiography image confirmed the CT findings of severe stenosis in left main and the proximal LAD. Dynamic CT perfusion image shows a significant decrease in microblood flow in the mid-anterior, anteroseptal, and anterolateral LV segment corresponding to left main territory. The patient underwent PCI for left main and proximal LAD stenosis. This patient had a calcified plaque in mid-LAD and dynamic perfusion CT image demonstrate severely reduced myocardial blood flow in mid-anterior and anteroseptal LV. Machine learning-based CT FFR showed very low FR value in mid-LAD and fourth diagonal branch. Invasive angiography confirmed tight stenosis in mid-LAD D1 bifurcation. Even though CT FFR is a promising method for non-invasive assessment of hemodynamic significance of coronary stenosis, gray zone of CT FFR value is always problematic for decision of presence or absence of myocardial ischemia. This study demonstrates adding CT MPI to patient with intermediate CT FFR result may be beneficial, improving diagnostic accuracy. Let's move on to the acute chest pain. Coronary CT angiography or triple route CT angiography is used to evaluate patients with acute chest pain who are at intermediate risk of developing major coronary artery disease. Among those without a previous diagnostic evaluation and no known coronary artery disease, coronary CT angiography or stressing test may be the initial method of testing. Second-line testing such as FFR CT may be helpful for patients with an initial inconclusive stress test. For intermediate risk patients with known coronary artery disease, coronary CT angiography is performed for non-obstructive CAD and stress testing is performed for obstructive CAD. Let's start with a representative case in which CT protocol, coronary CT angiography, or triple row CT would be better for acute pain evaluation in the emergency department. A 66-year-old man complained of acute chest pain and left shoulder pain on the day he was admitted to the ER. The initial cardiac markers were within normal limit. This patient was suspected of having acute aortic syndrome and underwent ECG-gated triple row CT. Acute aortic syndrome was absent, but severe coronary artery calcification was found in the LAD on a pre-contrast CT. Coronary CT angiography showed extensive calcified plaques in the proximal to mid-LAD, and myocardial infarction was noted in the LAD territory on early and delay-enhanced CT images. Emergent coronary angiography demonstrated a complete occlusion of the mid-LAD, confirming the CT findings. Chest pain is the second most common cause of ER visits and account for nearly 8 million visits annually in the United States. Acute coronary syndrome and acute cardiovascular disease like aortic dissection or pulmonary embolism are associated with high morbidity and mortality. The triple row CT angiography protocol played an indispensable role in triaging emergency room patients with acute chest pain. In the setting of troponin-positive acute chest pain syndrome, the addition of late contrast enhancement CT significantly improved the diagnosis rate of triple row CT. Initial evaluation of a patient presenting acute chest pain focuses on rapidly identifying patient with an immediately life-threatening condition so that appropriate medical intervention can be initiated. Potentially life-threatening causes of chest pain include acute coronary syndrome, acute aortic syndrome, acute pulmonary thromboembolism, triple row CT was associated with higher yield of pulmonary embolism and aortic dissection compared to the coronary CT angiography, especially in the emergency department. However, this benefit comes with higher non-diagnostic image quality, higher radiation exposure, and a large amount of contrast media. Although triple row CT may be of value in selected patient, its discriminatory use is not warranted. This study was performed 2015. For case of conventional ECG-gated triple route CT angiography with retrospective scanning mode, allowing simultaneous evaluation of the thoracic aorta, pulmonary artery, and the coronary artery with homogeneous contrast enhancement. This study investigates the diagnostic value of comprehensive triple route CT protocol, including both angiographic and a late contrast enhancement scan in 84 patients with troponin positive acute pain. 35 patients had obstructive CAD, 1 aortic dissection, and 6 pulmonary embolism. In the remaining 42 patients, late enhancement CT scans were obtained and the myocarditis was detected in 22 patients. A CT protocol including triple route CT and late enhancement CT scan improved diagnostic rate in patients presenting with acute chest pain syndrome. This is the case of acute myocarditis. Early and delay phase of CT showed early hypoenhancement and delayed subepicardial hypoenhancement in the basal inferior and the inferior LV were consistent with acute myocarditis. Delay enhancement MRI confirmed the findings of acute myocarditis. AI-based contrast enhancement and noise reduction in delay enhancement CT images improves diagnostic performance for the evaluation of acute myocardial infarction with subendocardial microvascular occlusion compared to original delay contrast enhancement. Recently released wide area digital CT scanner is able to capture the pulmonary artery, coronary artery, and the thoracic aorta separately, providing excellent image quality, low contrast agent use, and acceptable radiation dose to patient. This video demonstrates how to perform whole body CT angiography, including triple route CT. It's very fast and capture the pulmonary artery, coronary artery, and the thoracic aorta separately, providing excellent image quality, low contrast agent use, and acceptable radiation dose to the patient. Compared to the conventional triple route CT angiography protocol, due to the accuracy of time window of pulmonary artery, coronary artery, and thoracic aorta in wide area detector CT, triple route CT protocol, the differentiation of each vessels of triple route angiography is very clear. What do you think about this wonderful whole body CT angiography that involves the triple route CT protocol with one contrast agent injection and the low dose radiation exposure? Even though it provides such high quality images, would you hesitate to use the triple route CT protocol? I'll show you several cases of triple route CT angiography protocol using the newly released CT scanner. This case shows calcified plaque in the mid LAD. Machine learning based CT FFR value for LAD was 0.82. One-stop non-invasive complete anatomical and functional evaluation provide high confidence in ruling out significant CAD without the need for interpretation by a cardiac radiologist. Invasive angiography showed insignificant stenosis in proximal LAD. Triple route CT clearly demonstrate patent proximal LAD stent without significant instant restenosis. Triple route CT demonstrate complete thrombotic occlusion in mid to distal RCA and delay subendocardial hypoenhancement and akinesia in mid-inferior LV segment. Invasive angiography confirmed thrombotic total occlusion in distal RCA and intermediate stenosis and in LAD. Triple Raw CT clearly demonstrates normal coronary artery for Stanford type A aortic dissection. Triple Raw CT angiography showed acute pulmonary thromboembolism in both pulmonary artery, pulmonary infarction in right lower lobe, and severe pulmonary hypertension, as well as thrombosis in left common iliac vein. Triple Raw CT demonstrate calcified varicose aortic valve with severe AS, severe coronary calcification in 3 vessels. Echocardiography confirmed severe ES and invasive coronary angiography showed insignificant coronary stenosis due to frequent syncope and unstable hemodynamic status. Emergency transaortic valve replacement was performed after multidisciplinary consensus at night. In summary, chest pain is one of the most common reasons why individuals seek medical attention. CCTA play a central role in the diagnostic evaluation of stable and acute chest pain syndrome in patients with and without CAD, particularly intermediate risk patients with acute chest pain and no CAD, and chronic stable chest pain with no known CAD. CT-FFR and CT-MPI allow incremental diagnostic value over CCTA alone for the identification of hemodynamically significant CAD. Triple Raw CT angiography play an integral role in triaging emergency room patients with acute chest pain. Thank you for your listening.
Well, thank you very much, and I would invite the rest of the faculty to look at the questions in the Q&A and feel free to answer them. But for the sake of time, we will move on to our next speaker. Chung Ho Yan is going to discuss clinical application of cardiac MRI in cardiomyopathies. And very quickly, he's a staff radiologist and an associate professor at McKay Junior College of Medicine. He did his residency in the Department of Radiology, McKay Memorial Hospital in Taiwan, and then went ahead and did a cardiac MRI and CT training program in Massachusetts General Hospital in Boston. So it's very good to have you with us, Dr. Chung. If you could go ahead and start your lecture.
Hello, thanks for the introduction. And everyone, it's my honor to be invited to join this Bayer SCCT meeting. In the coming 30 minutes, I will briefly review cardiac MRI in cardiomyopathy. In the beginning, I will introduce traditional MRI sequence and the latest one later, as well as their clinical application in various cardiac disease. I believe most participants in this meeting doing cardiac CT. Of course, CT can provide information related to cardiac function by aiding a little bit extra radiation. However, cardiac MRI is still the gold standard for comprehensive assessment of cardiac function, including ejection fraction, regional wall motion sickness, and the motion abnormality. Late gadolinium enhancement is the kingpin of MR sequences for cardiac disease. We injected the gadolinium into patient's peripheral vein and waited about 8 minutes, performed the inversion recovery sequence. We could make the healthy myocardium completely new. Myocardium with fibrosis or injury would show delay enhancement in different pattern. This slide is the most important one related to the traditional MR sequence of this talk, because based on the distribution of LGE, we can differentiate ischemic and non-ischemic cardiomyopathy. For ischemic one, it's always related to coronary supplying territory, and the environment is the environment in myocardium is from subendocardial to transmural. On the other hand, in non-ischemic cardiomyopathy, it mainly involves mid-wall or epimyocardium, and sometimes the global endocardial involvement. T2 weighted imaging can detect myocardial edema, which is complementary to LGE. In this figure, we can identify the signal intensity increase in septal wall. T2 weighted imaging is very useful in both ischemic and non-ischemic cardiomyopathy. Takotsubo disease, also named stress-induced cardiomyopathy, transient LV apical ballooning, and broken heart syndrome. It was first described in Japan, named for an octopus trap. In clinical diagnosis of Takotsubo disease was about the patient without significant CAD and the depressed function of the distal and the apical segments with compensatory hyperkinesis of the basal segments with the apical ballooning change. In cardiac CT, of course, we can easily access cardiac function, apical ballooning, and the coronary patency or not. However, for the evaluation of myocardium, it's not the strong suit for cardiac CT. In this European Heart Journal paper, they collected 59 patients with suspected apical ballooning syndrome and performed CMR. The result was very interesting that after CMR, only 38 cases can keep the diagnosis of apical ballooning syndrome, and the 21 have alternative diagnosis. For example, in the left-hand side case, we can identify spotty LGE in the mid-wall of the lateral and anterior wall of LV, which is diagnosed as myocarditis. In the right-hand side cases, the transmural LGE involving LV apex is due to myocardial infarction. For this case, the initial MRI images shows the apical ballooning change with no LGE, and the T2 weighted imaging revealed increased signal intensity at the apical level of LV wall. The MR imaging 3 months later showed completely resolution of apical ballooning change. In our daily practice, echocardiography is the first-line image modality for patients with heart failure symptoms. For echo-diagnosed LV dysfunction cases, LGE is a robust tool to differentiate ischemic and non-ischemic cardiomyopathy. Compared to CMR, cardiac CT and nuke medicine are two much more popular modalities in cardiac imaging, but both of them can play limited role in this part. As we just mentioned about the limitation of CT, and for the salient scan has relatively worse spatial resolution and hardly differentiate subendocardial lesion from the transmural one. This is a 42 years old female who presented dyspnea on exertion, and the echo diagnosis was dilated cardiomyopathy. The invasive coronary angio showed negative. In signing imaging, we can see the dilated LV chamber with severe global hypokinesis and the paradoxical movement of septal wall. Without presenting the patient's clinical history and the CMR result, non-ischemic cardiomyopathy should be highly suspicious. However, LGE showed a large area of transmural delay enhancement in the LAD distribution. This is a typical imaging finding of myocardial infarction of LAD territory and consistent with the clinical information of this patient. She was a drug abuser and has stroke 1 month ago. This is a paper from Circ CV Imaging 2020. It is an international multi-institutional study. They enrolled 1672 dilated cardiomyopathy cases without significant evidence of ischemic cardiomyopathy. And the 650 cases of them had LGE on MR images. LGE patterns were coded as subendocardial, midwall striate, midwall patch, and subepicardial. In the analysis of cumulative incidence of the arrhythmic endpoint and the composite endpoint of death, LV assist or heart transplantation showed significant higher risk of patients with LGE. The upper figure revealed the adjusted impact of LGE presence on event-free survival, and arrhythmic event is consistent across different LGE patterns. In the lower figure showed the coexistence of multiple LGE patterns provide a gradient response with higher risk for increasing numbers of patterns in the analysis of event-free survival, but not arrhythmic endpoint. Let's move on to the LV hypertrophy, which is an independent predictor of future cardiovascular events. There are several different etiologies of LVH. Today, we will focus only on hypertrophic cardiomyopathy and the infiltrative heart disease storage disorder. For the normal thickness of myocardium, it should be about 6 to 8 millimeter in the end diastolic phase. Over 11 millimeter is hypertrophy, and over 15 millimeter, we call it hypertrophic cardiomyopathy. About the diagnostic tool of HCM, echocardiography is definitely the most popular one, which is much more convenient and inexpensive compared to CMR. However, for an important minority of HCM patients, CMR is capable of identifying regional HCM not recognized by echo, particularly in the hypertrophy involving anterior lateral LV free wall. There are several LV patterns of HCM. CMR can easily access the different phenotype. The left-hand side cases is left middle wall hypertrophy. We can identify the mid-wall hypertrophy and the apical aneurysmal change. The right-hand side case is LV apical hypertrophy, which revealed space-shaped LV cavity in the end systolic phase. LG of HCM revealed patch multifocal hyperenhancement, mainly within hypertrophy region, not related to coronary artery distribution area. We know that HCM is a common inherited cardiac disorder. These are 3 members of the same family. The father had larger amount, 40% LGE of LV mass with LV cavity dilatation. And the sum had 11% of LGE with LVH. The 22 years old daughter has negative CMR. So the most interesting part of CMR in HCM cases is that it could help to access genotype positive but phenotype negative cases. For this genetic diagnosed HCM patient with normal LV wall thickness, no cardiac dysfunction or chamber dilatation, but significant LGE in LV wall. This is a 27 years old male. Actually, he was an intern in my hospital a couple years ago. We can see a significant circumferential wall thickening except the basolateral inferior segment. And we can identify the diffuse patch and the spotty LGE involving LV wall. Fabry disease is an X-linked glycolipid storage disorder with the accumulation of GB3 and other sphingolipid through the body. In heart, it leads to progressive LV hypertrophy, valvular disease, and arrhythmia. To detect myocardial lipid deposition is of the essence. Mid-wall myocardial delay enhancement in the basal inferior lateral wall is the typical findings of LGE in Fabry disease. The LGE pattern in Fabry disease is quite different than HCM and amyloidosis, which reveal the global subendocardial LGE involvement. In this radiology paper discussed about LGE and LV hypertrophy in Fabry disease, they not only demonstrated poor survival and higher annual event rates in patients with LGE and LV hypertrophy, but even worse survival rates in patients with LGE, more than 15% of LV mass compared to those with less LGE. Okay, let's move on to the latest MR sequences. T1 and T2 relaxation times of tissue, whether cardiac or other organs, are quantitative magnetic properties that can be measured using MRI. Each tissue type exhibits a characteristic range of normal T1 relaxation times at a particular magnetic field strength. T1 is influenced by the biochemical and the physical properties of the tissue and its environment. Those are two most popular T1 mapping sequences in clinical work, Shimolee and Morley. In 1.5 Tesla, for both of them, we generally use 900 to 1000 milliseconds as the normal range of T1 mapping value of myocardium at rest. Extracellular volume is a marker of myocardial tissue remodeling. The normal value is about 25%. For native T1 value, we don't need enhanced MR, but to calculate ECV, we need native T1, post-contrast T1 value, and the HCT. This is a nice figure for assessing T1 value and ECV in various cardiomyopathy compared among normal myocardium and the cardiomyopathy. Only Fabry disease, only Fabry, iron, and fat deposition associated with low T1 value, others with higher T1 value. And for most cardiomyopathy except Fabry, they also have increased and high ECV value. In the clinical recommendations from JCMR, it's suggested to perform parametric mapping in various kinds of cardiomyopathy. This is our very first Fabry cases. A 62-year-old male with gene-positive Fabry disease. Shimolee native T1 map at our 1.5 Tesla machine showed significant shortening of T1 value in septal wall. This CV imaging paper enrolled 105 LVH patients and showed only Fabry cases with lower T1 value compared to patients with hypertension, HCM, aortic stenosis, and amyloidosis. The subgroup analysis revealed that compared to normal control, Fabry patients without LV hypertrophy still have lower T1 value. This is a 66-year-old male with Fabry disease under treatment. We can identify LV hypertrophy at septal and the inferior wall. In my hospital, we have a every 2-year MR follow-up protocol for Fabry disease. Compared to the previous CMR, we can identify the progression of LGE involving basal inferior and the lateral apical wall. And the quantitative LGE result showed 24% LGE of LV mass. In the follow-up imaging, the T1 value increased in the septal wall, which is not due to the improvement of the disease, but pseudo-normal related to the ROI mixed low T1 myocardium and the fibrosis, which has higher T1 value. T2 value was calculated from T2 relaxation time. The normal range is about 44 to 52 milliseconds. The number would be increasing in myocardium with edematous change. This is a 44-year-old man who is a heavy smoker, presented acute chest pain in our emergency room. The initial impression was acute myocardial infarction, but the angio result was no significant CAD. Cardiac MRI showed high T2 and T1 value of LV wall, and we can identify subepicardial LGE in the lateral wall. Then we can have the final diagnosis of acute myocarditis. This is a 44 years, sorry. This is a case of myocarditis after mRNA COVID vaccination. We can identify the high signal intensity at septal and the anterior wall on T2 weighted imaging, mid wall, and the subepicardial LGE, as well as the increased number of T2, T1, and ECV. This is a Takotsubo disease cases published in radiology cardiothoracic imaging, in addition to traditional MR sequences. We can identify higher T1 and T2 value of apical segment compared to the basal segment, which we could tell from the color mapping, consistent with the edematous change of myocardium. Okay, this is my last slide. As I say, most colleagues in this meeting must do a lot cardiac CT. So I made this table to compare CT and the cardiac MRI. Some sequences of MR like Singing, LGE, and ECV. CT may provide similar information. Some may be in our clinical practice, and the others may only in research field. However, about the T2 weighted image, T1, T2 mapping, we still need cardiac MRI for the assessment of cardiomyopathy. Okay, it's my talk, and thanks for your attention.
Well, thank you very much for your presentation and these lovely slides. So I'm going to quickly go over the questions. I think maybe we can take one, and then again, I'm going to urge the faculty to look into the Q&A and respond and type there. You know, one of the questions was saying, is there a cutoff for LGE burden in HOCM for ICD and pacemaker implantation?
Well, I believe there must be some data in the research field, but in general, we use 15% of LGE of 15% LGE of 15% LGE of LV mass as a cutoff value to evaluate significant fibrosis or not. Yeah, thank you.
Well, thank you. I think we have room for another question. We still have a couple of minutes before the next session. So one of the questions is saying that, you know, I suppose they're saying if there's patchy so the patient with amyloid on CMR, there's no global enhancement and no enlargement of the LV, normal kinetic motion, but increasing T1 and T2 value and patchy enhancement. So how does biopsy here fit in these patients?
So we have this kind of cases to perform biopsy, but in general, the biopsy they performed in the RV cavity. So they do the biopsy. The target region is in the interventricular septum, and I think that's why the cardiac MRI is so important, because we can have the global assessment of heart. And for biopsy, they can only have very small sample to examine. So sometimes they cannot really get the target at the right location. So I think we have biopsy results is good for some disease like Fabry disease. Always it's the distribution is always heterogeneous in the global, but for other diseases like sarcoidosis, you may need to have the biopsy at a very correct location to get the sample right. Yeah, thank you.
Well, thank you again, and I think we move on to our next and final talk for this afternoon or morning, wherever you are. It's Dr. Ming Yen. He's going to cover coronary plaque quantification by cardiac CT, a new era, and a very brief introduction. Dr. Yang is a clinical associate professor at the Department of Diagnostic Radiology in Hong Kong University. He is also course director of the Hong Kong University Cardiac Imaging Massive Open Online. He's done his fellowship training in Toronto General before coming back to Hong Kong, and he is a fellow of the American College of Cardiology, SCMR, and SCCT. And he is the chair of SCMR's Education Committee and a member of their Publication Relations Committee. And he is, of course, part of the SCCT Education Committee and an associate editor at the Journal of Cardiovascular Computed Tomography. So I'll turn it over to you now. If you can share your slides, yes.
So thank you very much for the kind introduction. And it's a real pleasure to be here to talk to you today about coronary plaque quantification by cardiac CT, a new era. I'd like to thank the SCCT and Bayer for the kind invitation to talk to you today. These are my disclosures. So in today's talk, I'm going to address the question, why measure plaque, how CT quantifies coronary plaque, and also discuss the limitations, areas of development, and the future. So we're all very familiar with the atherosclerotic process. We have essentially the buildup of cholesterol deposition and inflammatory processes that go on that produces the atherosclerotic plaque, and you can have either stable or vulnerable / high risk plaques. And with the vulnerable plaque or unstable plaque, if this ruptures to the degree to which the vessel thromboses, you'll develop acute coronary syndrome ranging from unstable angina to ST elevation myocardial infarction. Now, as this case demonstrates, the two patients on the left and the right demonstrates similar severe narrowing. But it's quite obvious that there is a very significant difference in the amount of plaque. The patient on the left has a lot less plaque, while the patient on the right has a lot more plaque. And common sense would tell us that the patient on the right probably is going to do a lot worse because there's just a lot more plaque in that patient. So that's one of the driving reasons behind the interest in coronary artery plaque. So why should we measure plaque, or at least what is the evidence that indicates that measuring plaque is a good thing? So one reason for measuring plaque is that it predicts major adverse cardiovascular events. In fact, not just does it predict major adverse cardiovascular events, it appears to even be better than, or at least more predictive of adverse events than even the number of obstructive coronary arteries that you have. So as you can see in this relatively recent paper, calcium scoring actually is a stronger predictor than the number of vessels obstructed, and it remains as an independent predictor to obstructive coronary artery narrowing. Now, if we look back at some of the even older studies, and this is a study that came out several years ago now, and what they showed was that the high-risk plaque is also predictive of outcome, and it appears to be even more so than significant narrowing. And furthermore, if you combine these two variables together, it actually performed even better in terms of predicting outcomes. So essentially, high-risk plaque presence plus significant narrowing is the worst, and those with no high-risk plaque features or significant narrowing did the best. And interestingly, if you have high-risk plaques, but with no significant narrowing, this appears to be worse in terms of predicting outcome than those that had significant narrowing and but without high-risk plaque features. A second reason for measuring plaque is that it actually predicts ischemia. This was a model that was looking at multiple parameters to see which parameters best predicted the presence of ischemia when measured on coronary CT. And what it shows is that essentially maximal percentage diameter stenosis is the most predictive. But interestingly, low density non-calcified plaque volume was the second most significant predictor of the presence of ischemia. Another compelling reason for measuring plaque is that it potentially can guide management. So there are no trials looking at outcomes of initiating treatment for high-risk plaques as far as I'm aware. But this particular trial, the Paradigm trial, looked at the effect of statins on coronary artery plaques, which had a more than or equal to 2-year interval between the first and second coronary CTs. And what you can see here is that the trial demonstrated that patients that were on statins essentially converted their non-calcified plaques to calcified plaques, indicating that essentially the plaques were becoming more stabilized with the use of statins. And this data has been further embellished by and added to the CADRADS 2.0 guidelines. So now, in addition to identifying high-risk plaques, the new CADRADS 2.0 actually advocates classifying how much plaque there is. So in this stable chest pain table, they have a classification from P1 to P4, and it gives different recommendations. And P1 is mild amount of plaque, but P4 is extensive. So as you can see, increasing amounts of aggressive risk factor modification is recommended depending upon the amount of plaque, indicating that essentially the experts recognize that the literature is moving in a direction that indicates that determining the amount of plaque is a useful parameter on cardiac CT. This was also advocated for those patients that are presenting with acute chest pain. Again, recommending the management strategies based on the classification of the presence of plaque in terms of P1 to P4. The fourth reason for measuring plaque is really that we have the opportunity to leverage AI's power. This is a really nice concept that was mentioned by Jim Min many years ago, and what he indicated or proposed was that if a radiologist or cardiologist reports, let's say, 20 patient cardiac CTs a day, and each cardiac CT has 20 phases, and each CT has 300 images with 512 by 512 pixels, this would actually result in 31.5 billion pixels, which is just too much for the human mind to comprehend. And there'll be a lot of data within these pixels that can be utilized to better risk stratify or to better understand the patient that is in front of us. So this has actually been acted upon, and this is a recent study that came out using artificial intelligence to diagnose significant narrowing. And what we can see here is artificial intelligence has a very high degree of accuracy, more than 84% to 86%, by identifying 50% or higher or 70% or higher stenosis on coronary CT. In addition, the identification of pericoronary adipose tissue attenuation is also a very interesting area that has been advocated. And this landmark paper showed that the change in the pericoronary adipose tissue composition is predictive of outcome. And really the concept here is the idea that as you're developing atherosclerotic plaques, this elicits an inflammatory response, and the fat that surrounds the plaques causes a change in the tissue composition from a more fatty composition to a more watery composition, and therefore raises the Hounsfield unit values. And therefore this can be measured. And this study very elegantly demonstrated that pericoronary adipose tissue attenuation is predictive of outcome. Another discipline that has taken a lot of interest with the amount of data that is being generated from our CT scanners is the discipline of radiomics. And in this, essentially, the discipline looks at multiple parameters and the way that the pixels relate to each other, and can produce thousands upon thousands of parameters. And in fact, this is just one example where radiomics was utilized to see whether it could provide incremental benefit in terms of risk prediction. And here we can see that essentially in these three models, model 1 was a cardiovascular risk model only, model 2 was just based on standard coronary CT parameters, and model 3 was essentially model 2 plus with the addition of radiomics, and it showed that there was a incremental benefit in terms of the prediction. This is a further study but interestingly, it's in the context of acute coronary syndrome. So this is really the fifth reason for considering measuring plaque. So very early on, Maros Frenchik and company showed that by utilizing cardiac CT to assess for and quantify plaque, according to the ROMI-CAT score, you could identify which patients were more likely to have had acute coronary syndrome in those patients that were presented to the emergency department and had a cardiac CT done as an emergency. This is a further study, and what they looked at was, instead of looking at just solely patients that presented to the emergency department, they looked at patients who were asymptomatic, those who had acute chest pain but were not due to acute coronary syndrome, and then those that had acute coronary syndrome. What they showed was essentially those that had acute coronary syndrome, interestingly, had more plaques compared to those that had acute chest pain or were asymptomatic. And if you then broke these plaques down into 4 different types, which were dense calcium, fibrous, fibrofatty, and necrotic, again, the same thing was demonstrated, where those with acute coronary syndrome generally have more plaque compared to the other 2 groups. And furthermore, artificial intelligence has also been used for predicting myocardial infarctions specifically, but this time what this study wanted to do was to bring in the newer marker of pericoronary adipose attenuation, as well as also low attenuation plaque burden, which had been shown to be predictive of myocardial infarcts. And together what they showed was both of them independently are predictive of myocardial infarction, but if you combine them together, there is an incremental benefit in terms of prediction of myocardial infarcts. So this now brings me to how CT quantifies plaque. So there are really three groups that you can divide the way that CT can quantify plaque. One is subjective, which is one way that CAD-RADS 2.0 suggests that we can quantify plaque, which is essentially just mild, moderate, severe, and extensive. But this is hugely subjective, and there is much more variability with this, understandably. The second method is semi-quantitative, and there are two main types. One is segment involvement score, or the Lehman score. The segment involvement score is the easier methodology, and I will explain this a little bit later in some of the subsequent slides. And I'll briefly touch upon the CT Lehman score a little bit later. And the last group is really the quantitative group, where we can get a lot more data, and it provides a lot more information. Of course, the most well-known of the quantitative measures is the coronary artery calcium scoring, which gives us the Agatston units, and this is, of course, exceedingly robust with a lot of data supporting its use, particularly in asymptomatic patients. And it produces lots of other parameters, such as the maximal percentage diameter stenosis, low density non-calcified plaque, total plaque volumes, percent atheroma volume, etc. So just to illustrate to you how the segment involvement score works, here's an example of a case with 3 areas of plaque, or 3 plaques that are demonstrated in this diagram. And essentially the segment involvement score works as such that you, based on the number of segments that have plaques, you will then determine whether it is mild, moderate, severe, or extensive. And essentially, if there are 2 segments or less, this is mild, so essentially 2 or 1. If there are 3 or 4 segments, it's moderate. If it's 5 to 7, severe, etc. And as you can see, since these are 3, this is technically going to be moderate. So the segment involvement score actually has a lot of data supporting its use, and this is a meta-analysis which demonstrates that in terms of major adverse cardiovascular events, it is predictive of outcome. The CT Lehman score is a semi-quantitative method, as I've illustrated earlier, but it is more complex than the segment involvement score and probably a lot harder to implement clinically. So just to give you an example, what would happen is you need to know the right or left dominance, or whether it's a balanced system. And then from there, you give weighting based on the plaques found. And it's based on their location. It's also based on whether there is obstructive coronary artery disease or non-obstructive coronary artery disease, and then what the plaque composition is. So here are just 3 different vessels. And just to give you an example, you can have one vessel here where its segment involved score is 1. CT Lehman score is 0.92, and then you can have another one where the segment involvement score again is 1, but the CT Lehman score is 2.15. So you can see that the CT Lehman score gives a much larger variables in terms of, or variability in terms of results, but it will be much more complex to implement clinically. So what about the quantitative methods or variables for measuring CT plaque? So one of the first things that really needs to be tackled is what kind of software package you're going to use. This is this is a table from an excellent review by Michelle Williams and her co-authors. It lists 6 different vendors, but this is by no means exhaustive. There are other vendors out there, but these are 6 that they have listed in the table. And essentially, the softwares are able to do various types of plaque quantification. One example is the total plaque volume, where essentially you measure or delineate the area of the vessel wall, and then the software will calculate the plaque volume. There is also the low density non-calcified plaque, which the software can calculate, and this is all done essentially whilst you're measuring the plaque, but you have to set the threshold, and usually most people will set the threshold at less than 30 Hounsfield units. But as you'll see from papers that are published, there are sometimes some variability in the cutoffs used. So in terms of quantifying plaque, there are here's just two different softwares demonstrating how the plaques are quantified. Here's one where essentially the plaque itself was quantified, and then here's another software. As you can see, the plaques are being quantified, but it appears slightly differently and is illustrated in a slightly different manner. So one key question really when it comes to quantitative plaque analysis is if you're using the same software but you have different observers, or the same observer but measuring at different time, or if you have, let's say for example, one scan compared to another scan, how much variability will there be? And this paper illustrated that essentially there is good correlation according to Lin's correlation coefficient. It should just be, I just want to caveat that the Lin's correlation coefficient is not the same as the Pearson's correlation coefficient, and actually the criteria for excellent is actually higher, and it has a much higher bar. So although the numbers look much better, essentially there isn't actually an agreed cutoff, but you should just bear in mind that you need a much higher score to consider this as being excellent in terms of reproducibility. But importantly, the p-values are not significantly different, indicating that essentially there is no significant difference when they ran these 20 cases with same observer or different observer, or a scan compared to a rescan. So what are the limitations, areas for development and future? Because obviously this technique is not perfect. There is no such thing as a perfect technique. So it's important for us to be aware of what these limitations are in order for us to have a balanced view and a knowledgeable viewpoint on how best to utilize this powerful technique. So one issue that needs to be highlighted is really that scan parameters and type play a role in plaque quantification, and it may not necessarily be the same depending on, say, for example, your KV or MA that you utilize for that scan. There is also a lack of standardization amongst different software tools. So essentially, it may not be comparable if, say, for example, you measure plaque on one software tool and then you use another software tool. This is, as far as I'm aware, not been done so far. Unfortunately, as things stand currently, plaque quantification with most of the softwares actually requires a long analysis time and usually requires an expert to review, which definitely limits its clinical utility currently. However, artificial intelligence will likely improve this. The other issue is also potentially we may be experiencing parameter overload, because if we get given thousands of parameters, that may just be too many parameters to review, especially in a busy clinic, to advise patients or change management. So this is just one study that highlighted that there is actually differences if you use experts versus non-experts and automated quantification. Essentially, not surprisingly, when you compare IVUS quantification of plaque versus the expert for quantitative cardiac CT, the correlations generally is very good, if not excellent. But if you compare it to non-expert, the correlation is not as good. It's good, but not amazing. And if you use an automated program, it's actually good, if not very good in terms of certain plaques, particularly the calcified plaque. There is also another issue when it comes to measurements. The studies don't always perform measurements the same way. One such example is the choice of whether you measure the whole vessel or whether you just measure plaques only. Doing one technique or the other will result in slightly different values. Essentially, if you measure whole vessel, you'll likely have a higher value in terms of the amount of plaques, because sometimes it's a bit hard to differentiate normal wall from plaque. While if you just measure plaques, then you'll probably have a lower plaque volume. So this is just some subtle nuance that you need to be aware of. There's also the parameter called percent atheroma volume. And it has various names, given sometimes a total plaque burden percentage or plaque burden volume ratio. And the other point is that the denominator is variable from paper to paper. So in the future, there'll be, I predict that there'll be a proliferation of AI companies. In fact, actually, we can see this at least at the latest SCCT meeting. You'll see that there'll be much more prominence in terms of AI companies and plaque quantification companies demonstrating the utility of their softwares and the useful data that this produces. I do also believe that actually cardiac CT plaque quantification can also have a very useful role in terms of guiding treatment for atherosclerosis. This is one of those exciting papers which demonstrated that icosapent ethyl, a new drug which demonstrated reduction in atherosclerosis, and this was demonstrated through using cardiac CT, demonstrating a reduction in plaque in those that underwent treatment. And I'll give the last word in this presentation to the recent publication of guidelines for quantification of coronary artery plaque. And what this group of experts did was they had experts from MRI, CT, nuclear medicine, intervention, echo, and they wanted to see, or they were basically voting on what they thought the different imaging modalities were able to do or not able to based on their experience and also on the published literature. So just to paraphrase them, they said that with regards to CT is the most appropriate modality for the quantification of total coronary plaque burden and for the assessment of coronary plaque morphology and composition. And in terms of the future, they felt that the development of new software for CT scanners will allow rapid and fully automated quantification and characterization of plaque in the whole coronary tree, which might ultimately be used as a support tool for routine clinical decision-making. So in conclusion, I believe that we're in a very exciting era where cardiac CT plaque quantification is definitely coming, and it will play a role in our clinical management of patients. And this will happen through the proliferation of AI companies and more software vendors providing plaque quantification. Secondly, plaque quantification provides additional information for management. I hope I've convinced you based on the various papers that come out that it helps in terms of patient risk stratification, and in terms of there are novel markers such as pericoronary fat attenuation and radiomics, which may play further roles in this. And lastly, I also think that plaque quantification will provide very useful target biomarkers for future drug development. And with that, I thank you very much for listening. And this is a picture of the medical school.
Well, thank you very much. And I'm seeing a few questions in the chat. Well, I think these are actually relevant to the prior talks that had come up. You know, they were talking about CT MPI and CT FFR. Are any features more specific about plaque vulnerability? So maybe I'll turn that over to any of the faculty who want. I mean, Ming, do you want to see that one?
Sorry, can you repeat the question to me, Mervat?
Yeah, so they were just talking about CT MPI and CT perfusion and CT FFR, and they're wondering if what is better predictor of plaque vulnerability?
I think that's a good question. I mean, CT-FFR is really measuring the significance of plaque presence and whether this is causing any flow restriction. And CT myocardial perfusion is really looking at the end stream result of either coronary artery plaque or even coronary microvascular disease. So as far as I'm aware, CT myocardial perfusion and CT-FFR is not actually predictive of vulnerability. This is where something like plaque quantification and plaque analysis is more predictive of plaque vulnerability, as far as I'm aware.
And you know, quite a bit of your talk was revolving around artificial intelligence. And so what do you say to folks who have reservations or concerns about artificial intelligence and its accuracy, but also, are we seeing the same thing that we saw in the Industrial Revolution, where people are so afraid of industrialization that they'll lose jobs? Or is artificial intelligence really here to help us expand our job?
I think that's kind of like the $1 million question, where I don't think we really know, but I kind of see it as artificial intelligence will definitely change the way we work. And I think it's coming. So we might as well ride the wave and just learn how to utilize and harness its power to better our societies, better our patients. And if it changes the way we work, then we just have to adapt to it. I think I remember there was a phrase that someone came up with once, which I can't remember who it was that I can attribute it to, but it was along the lines of, the imager is either going to be one that uses AI or one that basically doesn't use AI. That's essentially the future. So, and the one that doesn't use AI is probably the one that will end up being redundant, but the one that uses AI is pretty much the future. So that's kind of how I see it as well. AI will help us, and CT plaque quantification is definitely one of those areas. So I don't know for people in the audience whether they've tried quantifying plaque, but I can promise you it takes a long time, and you definitely want an AI to do it, not a human, once you've tried it yourself.
I agree. There'll probably be a niche area where AI is going to be particularly useful. So I do want to thank all our faculty for being with us today. Fantastic presentations. I do know that attendees will get a certificate of attendance, and they will get a copy of the video recordings from today. And I want to thank Bayer and SCCT for organizing this seminar. And have a wonderful day, or rest of your day, everybody.